Okay, nutrition care process, assessment. This is the A in ADIME. These videos are created to help you better understand the material in the textbook. My recommendation is to read the text, watch the videos, and you should be prepared for any quizzes or activities that we do in class. So today, this video is going to talk about the assessment part of the nutrition care process, often abbreviated NCP. And ADIME is really the nutrition care process. So assessment, diagnosis, intervention, monitoring, and evaluation. And today we're going to talk about the assessment part. So before we get to that, we're going to talk about the purpose of providing nutrition care. Your job as the dietitian or the nutrition professional is to identify any nutritional problems, things like nutrient imbalances, and then correct those. So we got to get at what's causing the problem, and that's really what we call the etiology or root cause. And this is what you are doing. This is what you as the dietitian will be intervening to fix, to target. What can you do to help the patient resolve what's causing their nutritional problem? The etiology is something that you can do something about. So, I have, if we say that there's inadequate energy intake related to cancer, cancer is not the etiology that you can do something about. That's the physician's job. They're trying to fix the cancer. You're trying to fix something else. So, a better statement, nutritional diagnosis statement would be that the patient has inadequate energy intake related to decreased appetite, because you as the dietitian might be able to send them more calorically dense foods so they don't have to eat as much. You might be able to send them things that they really enjoy so that their appetite is sort of peaked. And so thinking about what you as a dietitian are going to do to fix the problem. This is patient-centered as well, so if you can talk to the patient and figure out how you might be able to fix their problem, then that will go a long way in making sure that they are adherent to whatever it is that you do for them or suggest. So there are a number of factors that can influence nutritional status. Your book has a table on these. Let me highlight a couple of them. Plain old biology, age, sex, genetics. These things will influence your nutritional status. Physiological phases of growth. So if you have a child, who we really don't talk about pediatrics in this particular course, but if you have a pregnant patient or someone who is lactating, these conditions, these physiological phases require additional energy, and in some cases additional nutrients. Your patients will probably have some sort of disease. They maybe have just experienced trauma, like a surgery, and through their disease process, organ function may differ, metabolism may be increased or decreased. So those are a number of biological factors that will influence nutritional status. Lifestyle factors are also important to consider as a dietitian. Does your patient or client have specific attitudes or beliefs that lead them to engage or refrain from consuming, different things? Do they understand? Do they have a good knowledge base about why they should be doing things the way they should be in terms of what their diet is, asking them to do or suggesting that they do? Why do I have to reduce my sodium intake if I am a cardiac patient? And then we get into sort of factors beyond the individual. So culture plays a big role in our attitudes and beliefs and knowledge about foods. So these are important things that you may want to ask your patient about as you interview them. So your book defines the nutrition care process as a systematic problem-solving method to make, decisions to address nutrition-related problems and provide high-quality nutrition care. And then this is the ADIME method here. We're going to assess, we're going to diagnose, we're going to intervene, and monitor and evaluate that intervention. ADIME is the charting format that we use in this course. It's taken on increased popularity, I guess, ever since the NCP was initiated. When I was in the hospital, we did SOAP noting, which is subjective, objective assessment and plan. It's really ADIME, just things are slightly moved around and compressed a little bit into the various categories. There are other charting formats that you may come across during your internship, but believe me, if you can do the ADIME, you can do any of these others. Just for your information and to call attention to this fact, you got to remember that the chart is a legal document. It can be used in court cases. It is something that you are representing your expertise on, so you should not chart for other people. Remember that if you didn't document it, it did not happen. So if you did a fantastic diabetes education for a patient, but you didn't write it down, there's no evidence to see, to say that they actually received education. And if I'm writing the follow-up note on that patient and you did it during the initial visit, and I see that doesn't look like you did the education, I'm going to go in and try to educate that patient. They may get a little testy because they really, do I have to listen to this again? So document, document, document. Don't chart in advance. Always do chart after you've seen the patient, and sign all of your notes with your credentials. And A&D is very particular that you do not use RDE, which is RD eligible. So if you are not an RD or RDN, don't use any other credentials but those. The assessment, here we go. Your job as the assessor is to obtain and interpret data to determine the nutrition diagnosis. This is the data collection phase. This is where you interview the patient. This is where you go over the chart, look at the labs, collect all of this information to begin to form your nutrition diagnosis. You're using this assessment phase and all of the information that you collect to assess the effectiveness of your nutrition intervention once you've developed it. So by looking at what's going on currently, and when we follow up with the patient, we'll be able to see if what you're picking up on in the assessment phase is actually improving. You want to quantify to the extent possible what's going on with the patient. So use numbers when you can. They're consuming about 60% of meals. That gives me a good indication, if I'm following up, how they're progressing. Are they now eating 30% of meals, or are they now eating 80% of meals? Even though you could even say eating fast food most meals, that at least gives me some sort of indication that, if patient was now eating fast food twice a week, that would be an improvement. So you could document that. Using objective reference standards and comparing your patient to those standards is critical in the assessment portion. We're going to talk about that more in Chapter 3, but examples of these comparative standards would be that the patient is 90% of their usual body weight or 140% of their ideal body weight. And I'll show you how to calculate those numbers in the near future, so stay tuned. In your assessment portion, you want to include age, sex, race, ethnicity, and medical diagnosis. All of those things can be biological factors that could influence their nutritional needs. If you can get some sort of diet history from the patient or from their caregivers, that would go in the assessment box. Anthropometrics, and again, comparing them to reference standards. So every patient should get a height and weight when they're first admitted. The computer may calculate BMI for you, or you'll have to do it, but often that's used as a screener to see, who might qualify for rapid dietitian assessment. Percent ideal body weight and percent usual body weight. Sometimes these can be, the percent usual body weight can sometimes be calculated on previous admission information, but oftentimes you have to ask the patient if they've lost or gained weight in the recent past. Biochemical data, these include your labs, any results from tests or procedures that would be nutritionally relevant. Nutrition-focused physical findings, we'll talk a little bit about that when we talk about malnutrition. There's social history that might be playing into any means by which they are suffering from nutritional problems or things that might help them reach their nutritional goals. So things like, if the patient is homeless, that's really going to restrict their ability to probably comply with whatever nutritional feedback you're going to give them. If the patient doesn't cook, then expecting them to whip up homemade meals that are low in sodium is probably not going to fly. If son visits the home regularly, you know that they've got somebody who's going to check up on them, and hopefully you could talk to the son and give your advice to him as well. So some thoughts just on social history that can be helpful. This is the nutrition documentation form that we use in this course. You'll use it in 472 as well. But you can see the A portion, the nutrition assessment part. We've got a couple of different boxes for you to put your information in. Client history, nutrition-focused physical findings, anthropometrics, food nutrition related history and comparative standards. That's where you're gonna talk about your usual body weight, etc. And biochemical medical tests and procedures. So that's where your labs and things like that would go. We'll get to the D in the next set of slides, and then intervention, monitoring, and evaluation as well. So here's a little mini case study that tells us a little bit about J.O. He's a 47-year-old Hispanic man admitted after suffering a myocardial infarction. He's 5'11" and weighs 235 pounds. His BMI is 32.8. He's married with 3 children. He used to play some college baseball when he was doing that, and he was 185 pounds. Now, he has a 17-year-old, so you know that he did not recently play college baseball, and he's 47. So that should clue you in that while interesting, that might not be terribly relevant to our case right now. When he stopped playing and began coaching, his weight increased to 200 pounds. Then about 3 years ago, he took a job as a junior high school principal. Principal's job requires much more desk work, so he's probably pretty sedentary. And despite walking the halls regularly between periods at the large urban school, J.O. doesn't get much exercise, so that confirms our initial thought. He eats fast food for lunch daily because he doesn't have a lot of time, and he's verbalized to you the need to get back in shape. So I kind of went through maybe what's of interest to us as dietitians. I used to weigh 185 pounds. You got to be careful about that when people tell you what they usually weigh. So, they'll go back to high school. Like, oh, in high school I weighed 125 pounds. Like, okay, well, you're now 60. That doesn't really help me. And the reason that the time frame is important is because it can signal someone's susceptibility to malnutrition. So timing is everything. Now, if they've gained a lot of weight in the past 6 months or lost a lot of weight in the past 6 months, then we need to give that a more critical review. He's married, so hopefully he and his wife together are making decisions about menus and foods that are eaten and things like that. So that might be important to talk to the wife, see how involved she is in, making decisions about that. There are other things that are of interest. Obviously, his height and weight and BMI is important to us. The sedentary aspect of his lifestyle also will influence how many calories we suggest he consume and things about that. There may be other things that you want to know about him. We don't know about, say, his food allergies. There are other things that we might be interested in. And maybe his willingness to stop eating fast food, maybe to pack a lunch. So there are a lot of things that you won't know just by looking at the chart. You will need to talk to the patient or caregiver about. And again, just to throw this back up here, things that you want to be thinking about as you talk to your patients. So, to summarize, the assessment is the first step of the nutrition care process. This is the basis for everything you do, so you should take your time and be thorough. But not so thorough that you're getting, drawn off track by things that are not of importance to you as the nutrition professional. So, they broke their arm 3 years ago. Well, if everything has healed, big deal. Probably not super important. But if that was the first of several fractures and may be indicative of osteoporosis, that's when you might be more interested in that broken arm. So you got to think about what the ramifications or what the consequences are of the things that you're looking at, and always keeping in mind the nutritional aspects of those findings. So we'll move on to diagnosis next, and that's it for today's video set.